All right, welcome back, everybody. We're going to go ahead and get started with Chapter 19 lecture, and we're basically just going to break down this CPT manual or the CPT book, as I mentioned in the video, and hopefully you watched the video first, and now we can go more in depth with the lecture about the CPT manual. So as I mentioned, CPT manual, or excuse me, CPT stands for current procedural terminology. And these are basically every procedure that we perform in a code format. Whether we see the patient in an office visit, in the hospital as a visit, or if we perform any type of surgery or procedure, whether it's hospital or in the office, okay? It is based off of different sections, and you have 6 main sections of the CPT manual, and that is your evaluation and management section, which again is the office visits, and the hospital visits are just visits in general, whether it's hospital, office visit, or skilled nursing facility visit. And then it breaks it down for surgeries and procedures. So then you have anesthesiology, surgery, radiology, pathology and laboratory, and then medicine. The medicine tabs, as you saw in the video, you have medicine just in general, then you have your vaccines that are considered medicine, then you have your psych meds, you have your dialysis meds, your gastrointestinal meds, your ophthalmology meds, endocrine meds, allergy meds, behavioral health, neuro medications. It's going to include every single medication except for anesthesia, because anesthesia has its own section. So if you're looking for any type of anesthesiology medication, you're going to have to go to the anesthesiology section of the CPT manual, okay? All right, so those are the sections, and for homework purposes, it's going to ask you where the sections start as far as the ranges of codes. And in your LearnSmart that you did, as well as in your textbook, the very first page of Chapter 19 has a little graph, a little picture. I think it's not named. It doesn't say what figure it is, but it's on the first page, and it says CPT codes are organized into 6 main sections. It tells you the section, and then it gives you the range of codes. You'll need to know those range of codes for your homework for tonight, okay? So make sure that you review that picture in your book so that you can follow along with that assignment for tonight. All right, there's different types of symbols that we use for different types of codes that we might select. It also gives us information depending on what information may have changed within the CPT manuals or the CPT codes. And I'm just trying to find that for you guys, because there's a nice image that shows you all the different symbols. And if you'll give me a second here, I can find it for you. Well, I had it. I don't know what happened to it. This stinks, because it was a really good picture too for you guys. Sorry if you hear some crying in the background. It sounds like my granddaughter is not happy right now. Let me see if I can pull it up this way for you guys. I had a really nice image and I don't know what happened to it, so I apologize. Okay, so this is very similar to in your book here. So the blue triangle, if you see it before a CPT code in the manual, it's basically indicating you that the code description has been revised. So you want to make sure you read the description, read the wording to see what has been changed. If it has a red dot in front of the code, this indicates that it's a new code. It's a new addition book or manual. They come out every year. So right now is the 2020. And if there's been any codes added from 2019 to 2020, you're going to see a red dot in front of them indicating that that's a new code. Hashtag or the pound is going to mean that the codes are out of numeric sequence, meaning they're not going to follow sequence. It's not going to be 99211. The next one's not going to be 212. And the next one after that isn't going to be 213. They're going to be out of numeric sequence. So they might not all, fall in sequence with each other. If you have brackets, which are two green triangles pointing towards each other, but the codes are in between these two triangles, then this just indicates that either the codes are new or we've revised the text information or we've revised the some of the description. So again, you want to pay attention to the reading, that the words in the description to make sure that it is exactly what you are pertaining to as far as the procedure that was performed. And again, I just want to kind of drive this home with you guys is for the ICD-10 and CPT manuals, it's not that you have to know all this stuff by heart before you get out on the field. You just need to know what these are, and we just need to make you familiar with them because technically, your billing department handles the CPT coding and the ICD-10 coding, but you just need to be aware of what they are and familiar with them. And the ones that you'll work the most with are going to be your EM code, which is for office visits. And then, of course, if you do any type of laboratory procedures in the office, like urinalysis or EKGs or blood work or throat cultures, anything or any type of rapid testing, if you do stress test, if you do some type of imaging in the office, those are the codes you're going to be more familiar with. And most billing departments in the clinic will create what we call a cheat sheet that will have the most commonly used CPT codes for the office. And then you'll really start to memorize those because you'll use them frequently, like every day. So the image I showed you are the most commonly used symbols, but there are other ones. You're going to have the circle with the diagonal line indicating multiple procedures or add-on codes can be used with the CPT code. A lightning bolt image symbol signifies that the medication is still pending FDA approval. So just because it's in there and we can use it, it doesn't have FDA approval, so it doesn't have the support from the Food and Drug Administration. The bullseye symbol is used for moderate sedation coding, and this is if you use some type of moderate sedation, you have to use that code, and that code will be indicated by a bullseye symbol, telling you that that is a moderate sedation code. Okay. So the CPT code format is always 5 digits unless there is a modifier that's added on to that or if there is an add-on code. But the add-on code is always going to be another full 5-digit or 5 numerical code. So add-on codes are your codes that are used to describe procedures done in addition to the main procedure, and it's always going to have a plus sign in front of the code. So an example, if I did a debridement of extensive eczematous or infected skin, up to 10% of the body, I'm going to select code 11000. But if I did more than 10% of the body, then I'm going to select the code underneath it that has a plus sign, and it's 11001. And this just indicates that I did, for each additional 10% of the body surface, I can bill for that. So remember, ICD-10 coding and CPT-10 code, or excuse me, ICD-10 coding and CPT coding is our way of letting the insurance companies know what we did in numeric format. And then that's entered into like a kind of like data entry, and then they reimburse us based on the level of code selected. Okay, you saw me in the book earlier. I showed you what the category 2 codes and the category 3 codes are. Your category 2 codes are optional codes. These are supplemental tracking codes used to track patients' performance measures, such as counseling for tobacco use, counseling for alcohol use, counseling for any type of drug use. So these are more your performance measure codes. And then your category 3 codes, as I mentioned, also or showed you in the book, these codes are to be used instead of any type of unlisted codes or codes that aren't used anymore, or codes that are both found directly after the last medication code if you're submitting for a type of medication code. So an example of a Category 3 code would be an implantation of a total replacement heart system or an artificial heart. It's a temporary situation. It's not permanent. We can't permanently implant an artificial heart into somebody. It's only there to bypass until we can get a heart for the patient. So your Category 3 codes are temporary codes, okay? Modifiers, these are one or more 2-digit modifiers. We can use one or more, but they're only 2 digits. So the cap on using these for each procedure code is 4 modifiers to each procedure code, but they have to be assigned to the main procedure code. So I have actually, I know I have images of this, so let me go to those real quick. Where? Hang on a second. These I know I have. Oops. There they are. Yay. These ones I know I had. All right, so these are some examples of your modifiers. And these are in your book too, so you can review these. But I can tell you the most commonly used modifier is the 25, and that's this one here. This one right here. And this is one that is used for patients that have more than one service done along with the office visit. So you can see here it says significant separately identifiable EM service by the same physician on the same day of a procedure or other service. So it's another service in addition to the office visit or EM code. So what I would do, an example would be patient came in for consultation for chest pain, and because they were having chest pain, the doctor ordered an EKG. So when I submit to the insurance company for billing, my billing claim, I am going to add my 99213 new patient comprehensive EM code, and then I'm going to add a 25 modifier to it for doing the EKG. So an example would be down here, the 99213. This one here says 99212, but I said 99213, which is just a different level of office visit. And then I'm going to put a dash 25, and that indicates to them that I did the EKG the same day as the office visit. And then I can also submit the 993000 for the EKG code. So that's the only time that you would submit an additional code as an unbundle versus bundling, because you add a 25 modifier to it. I know this can be confusing. Please don't feel like you have to remember this stuff. Just know that add-on codes are basically in addition to main procedures, and then your modifiers are other procedures done with an office visit code only, okay? That's all you need to remember on that. There's some commonly used coding terminology. Bundled codes are codes that are used together, meaning they are going to have like a 99212-99214. So any codes in between that are included, and that's what we call bundled codes. Okay, and then your concurrent codes are basically when you have care being provided by, and it's similar care being provided by more than one physician, you can use concurrent care codes. Critical care, this is when the patient's unstable, or your critical ear patients, they constantly need bedside assistance or attention. These are going to be your hospital admission patients, and the patient, so the physician's documentation has to be very, very precise and explicit regarding the amount of time that was spent with the patient. So these are going to be your more 99205 to 99215 hospital EM codes. So these are your 45 minutes for follow-up, 70 minutes for new patient codes. Consultations are patients that visit doctor's offices at the request of their healthcare provider or their primary care doctor. The consultation codes include 99241 to 99245. And then outpatient consultations are 99251 to 99255. Oh, I'm sorry. I totally mixed that up. Outpatient codes are 99241 to 99245, and your inpatient codes are 99251 to 99255. My apologies. I always would get those mixed up. The only time a service can be considered a consultation is if it has the 3 R's present, and the 3 R's are request, which is from another practitioner, record, which is recording the documentation, and the findings and the recommendations. And then the last R is report, and that's reporting back to the referring physician who referred the patient to you initially. Counseling is considered part of your evaluation management services or your EM codes, but if a complete history or physical exam doesn't take place, then counseling codes can be used. So it's kind of in place of the EM code, or when the EM code cannot be used or is considered inappropriate to submit. Downcoding is a term used when the insurance carrier bases reimbursement on a code level lower than what the provider submitted. So an example of this would be if a provider saw a patient for an hour, but we didn't want to bill the insurance that much because that was going to cost the patient more out of their pocket for their deductible. So the provider went ahead and agreed to bill them for a lower level for 15 minutes. So instead of billing the 99215, we billed for the 99213. That is considered downcoding, and that is considered insurance fraud. You cannot do that. If you spend 70 minutes with the patient, you have to submit your code that lines up with how much time was spent with the patient. Because if you spend a lot of time with the patient, then your progress note is going to be very long. It's going to be at least 2 to 3 pages. And you always have to submit your progress note along with your billing claim to the insurance company for reimbursement. So they're going to know you spent more than 15 minutes with them anyways. So you just don't want to be involved in a situation where insurance fraud is being performed. Okay, unbundling is basically stated as its definition. It's when you break down a bundled code into its component parts and you're trying to get higher reimbursement. Obviously, this is not allowed. An example of this one would be the unilateral, meaning both breast, right? Meaning one breast, uni meaning 1, bi meaning 2. So the code 77055 is defined as a mammography for one breast. You wouldn't take both those codes if you did a bilateral mammogram. You wouldn't use 77055 for each breast. You would use the 77056, which indicates you did a bilateral mammogram. So again, let me explain that. If I came in for a mammogram and they were going to do my mammogram on both breasts, then my doctor is going to submit to the billing insurance claim as a 77056. That is a description that both breasts were tested as a mammogram. If I had just one breast done, meaning unilateral, then I would be using the code 77055 for just the one. I couldn't use 77055 for each breast. I would have to use the bundle code, and that bundle code is the 77056. So again, unbundling is not allowed. That is also considered fraud. So from downcoding to upcoding, so you're downcoding, unbundling, and upcoding, those are all considered not allowed and are considered performing fraud, and your doctor can get in trouble for doing that. So make sure that is not happening, okay? Upcoding refers to coding procedures or services at a higher level than performed, opposite of downcoding. So the reverse to that would be, I only saw a patient for 15 minutes, and as the provider, I wanted to get reimbursed more, so I lied and said I saw them for 70 minutes. So instead of billing for a 99212, I billed for a 99215. That is insurance fraud. It's a lie. It's illegal. Again, don't get involved in that kind of stuff. Okay, remember earlier I said that in the book we have this this tree that explains how we determine a new patient. And this is how we determine a new patient. So what we do is, if there's any services received by professionals, healthcare professionals, from either the physician or another physician in the group who has been seen in the last 3 years, they are considered a established patient. Okay. If they have never been seen before, or it's been more than 3 years, then they're considered a new patient. So question is, has this patient received any professional services from the physician or another physician in the group of the same specialty within 3 years? If the answer is yes, then we go down here. The next question is it from the exact same specialty? Yes. Okay, then we go down to, is it from the exact same subspecialty? If we say yes, this is an established patient. Let's go back up. What if it's not from the same specialty? What if I had a doctor's office that was family care and pulmonology, and my family doctor wanted me to see the pulmonologist? So even though I had been seen in the last 3 years to the group, I've never seen the pulmonologist, then it's not the same specialty, and so therefore I am considered a new patient. Same thing if you came down here. Same specialty, yes, but then subspecialty. Let's say that after seeing the pulmonologist, they sent me for pulmonology rehab, wanting to build up my lungs to be able to work better, work harder, work stronger. So let's say they sent me to physical therapy. Okay, that is considered a subspecialty. If I had been seen by the primary care doctor 2 times and they said, no, we don't need them to see a pulmonologist, we need just them to get physical therapy to help strengthen their lungs. If it's no, not in the same subspecialty, then again, they're considered a new patient. If they've never been seen and haven't been seen in the last 3 years, then they are considered a new patient. So hopefully I didn't confuse you, but that basically just determines if you're a new patient or an established. And the simpler way to remember is, have you been seen in the last 3 years? Yes. Okay, you're established. If you haven't been seen in the last 3 years, or you've never been seen at all, you are a new patient. Okay. Some key factors to remember when determining service level: you always have to make sure you get the patient's history, do a full examination, and then this your medical decision making determines the level of service as well. The more time you spend gathering the patient history, the more time you spend doing the physical exam is going to determine whether it's a short service level or a longer service level. And then some of the contributing factors in assigning these EM codes is going to be how much time you spent counseling, how much time you spent on coordinating the patient's care, what was the nature of presenting problem, which is the illness, and then you have to track the amount of time that was spent with the patient. And the way we track that is we put all this information into our progress note based off of the SOAP format or the Cheddar format, as we discussed in the class prior to this one. Okay, this is something really interesting that you'll need to know with surgical coding. Anytime a surgery is performed, any follow-up or subsequent care after the surgery is included in what we call the surgical package or the global period. The global period is basically any type of follow-up care that is provided within a 90-day period after the surgery. Okay, in your CPT manual, your surgery sections are going to be your integumentary, musculoskeletal, respiratory, cardiovascular, and your hemic and lymphatic systems, including the mediastinum and diaphragm. So when these sections, these are your surgery sections, and a global period is used for anything that is pertaining to the surgery after or post-surgery. So an example, a global period for repairing a tendon might be set for 15 days. But if they have a major surgery, then it can be up to 30 days. And this would be follow-up to take a look at the incision. It would be follow-up to test, again, the lungs, to do a stress test if it's a cardiovascular surgery, check for scarring if it's an integumentary surgery, that type of thing. So depending on even physical therapy, if it's within the 90 days, that is within the global period. It's included in the surgical package. You can only use that surgical code, and it includes the global period or the 90-day follow-up care period. Okay. Hopefully you guys are following along okay, and I'm not confusing you or boring you too much. So I already went over these sections of the CPT manual, so I'm not going to break these down. But again, these sections are basically all tabbed together by the different body systems, okay? And I went over those with you guys already, so I'm going to skip over these. When we are using the CPT manual, you have to make sure that you verify your procedure in its documentation. So you are using the progress note to verify what procedure was done. You're always going to go to the back of the index to look up the code or to look up the procedure first. So again, if I did a, let's see. Well, let's say I did an EKG. I would go to the index. I would look up electrocardiogram. It would tell me to go to the 933 or 93000. So then I would go to the 933 and I would look and see what that description said. 93. And I'm just looking that up so that I can read it to you. 93000 electrocardiogram routine ECG or EKG with at least 12 leads with interpretation and report, meaning the physician has read it and we have reported the indications to the patient, and we have documented the findings as well. So that's how you would look up the procedure code. You would look for the procedure first in the back of the book, then go to the code that it indicates, and then verify the documentation or the description before selecting the code. Okay, verify the procedure code from the tabular list, and those are in your tab sections. Find out if you can use or need to use a modifier, and then make sure that you add a diagnosis code along with the CPT code in order to submit for billing. That is called code linkage, and we'll talk about that more in Chapter 17. Okay. HCPCS coding manual. This is your healthcare common procedure coding system. Your HCPCS level 1 are basically your CPT codes that we have been discussing, and then your HCPCS level 2 codes are primarily used by the Center for Medicare and Medicaid Services. These are called your national codes, and these just cover medical supplies such as sterile trays, drugs, injections, and durable medical equipment, whereas your level 1 codes are known as your CPT codes or your procedure codes. Coding compliance. We will talk about this more in Chapter 17, but I want to kind of explain it a little bit now. Code linkage is basically you have to have a diagnosis code with the CPT code in order to submit to the billing for reimbursement. If you submit a CPT code without a diagnosis code, they are going to kick it back. It's going to be denied. They're going to tell you that it's missing a CPT code. You can resubmit it once you add a CPT code to it, but just know that code linkage is basically meaning that the diagnosis code is present with the CPT code. We talked a little bit about insurance fraud, down coding, unbundling, and up coding. Those are no-nos. Those are not allowed. So you want to make sure that as a physician and as an employee to the physician's offices, that they are not falsely representing services or charges to the payer, because it's just wrong. They can be reported to Medicare. They can have their license taken away. It's just not worth it. I've worked for doctors who've tried to do this, and they've gotten caught every time. So that's why it's important to make sure that the office you work for has compliance plans in place to avoid the risk of fraud, and to avoid being being audited by Medicare or the other insurance companies, just to make sure that you are following the correct submission for insurance claims. You want to make sure that you're preventing any illegal medical office practice wrongdoings or doings, such as submitting for down coding, up coding, or unbundling. So it's really important to avoid that as much as possible, because that can cause a lot of headache, can cause more work for everybody, and it just doesn't look good. And actually, if insurance fraud is committed and you are the physician is found guilty, they can lose their license. They'll have to pay a very large fine, and they can even possibly go to prison. So not something that you want to mess around with, not something you want to be involved with either, because even though we don't have licenses that can be taken away from us, just think about if you worked for this doctor's office, it was your first and only job, and it was on the news that this doctor was arrested for insurance fraud, and then you go looking for another job and your only work experience is this doctor who committed insurance fraud, and everybody knows this about this doctor. So you go to interview and they say, oh, you used to work for Dr. Smith. We heard he committed insurance fraud. Did you have any connection to that? Did you have any, were you involved in that? Did you have any involvements in that? You just don't want to be in that situation. I know sometimes it's, well, I need this job, I need the money, but what it comes down to is morals and values. And it comes down to integrity. And you actually take an oath when you graduate from this program that you will do the right thing, that you will conduct with code of ethics. And when you get into sequence 3 with Miss D and the MDA classes, you will take a class for medical law and ethics, and you will be taught why it's so important to follow the laws. And it's just ethical, okay? So we want to make sure that we are not preventing that at all possibilities and in all cases. If you guys have any questions, please feel free to contact me. As you know, I will be in class till 7, but you are welcome to email me, and you know that I will get back to you as soon as I can. You ladies have a great evening. If you need to set up a one-on-one with me, please just email me and request that. All right, we'll talk to you soon. You guys have a great day.